Inside the lungs of a patient experiencing a severe asthma exacerbation, the bronchial tubes rapidly contract, the inner lining swells, and thick mucus completely obstructs the airway. When this state of severe airflow obstruction refuses to yield to initial standard bronchodilator therapy, the patient has entered status asthmaticus. Historically, emergency medicine relied heavily on short-acting beta agonists, or SABAs, to force the airways open. This approach treated the immediate symptom, the bronchospasm, but completely ignored the underlying eosinophilic or neutrophilic inflammation. Attacking the bronchospasm without suppressing the underlying inflammatory cascade leaves the root cause intact. This incomplete strategy fails to prevent the progression toward fatal acute respiratory failure. To correct this, the Global Initiative for Asthma, GINA, updated their 2024 guidelines with a clear mandate. The medical community must abandon SABA-only rescue therapy for adolescents and adults. The new standard of care is maintenance and reliever therapy, or MART, utilizing an ICS formoterol inhaler as the primary track 1 intervention. Formoterol provides the immediate bronchodilation a patient needs to breathe, while the inhaled corticosteroid simultaneously delivers targeted suppression of the exact inflammatory cascade driving the attack. MART represents the optimal first line of defense. But when a patient breaches this defense and progresses into status asthmaticus, clinicians must rely on a rigorous, stepwise escalation protocol. In the emergency department, subjective clinical assessment is inadequate for triaging severe respiratory distress. Clinicians require strict objective severity stratification tools. This chart outlines the pediatric asthma score. It relies on thresholds for respiratory rate and oxygen. Points are aggregated. A total score of 12 or greater, indicated by markers like oxygen below 90% or accessory muscle use, means severe asthma requiring continuous interventions. The initial resuscitation must prioritize targeted oxygen therapy. For adults, the target SpO2 is 93 to 95%, while for children, the target is 94 to 98%. Once oxygen is stabilized, the primary pharmacologic sequence begins immediately. High-dose albuterol combined with ipratropium bromide, administered alongside systemic corticosteroids. Relying on objective scoring prevents deadly delays. It ensures that the aggressiveness of the initial anti-inflammatory and bronchodilatory response matches the severity of the exacerbation. If a patient shows no clinical improvement within 60 minutes or their PAS score worsens despite initial interventions, primary therapy has failed. The immediate next step for moderate to severe exacerbations unresponsive to inhaled treatments is intravenous magnesium sulfate. At the cellular level, magnesium ions actively block calcium influx channels. Without that calcium, the contracted smooth muscle in the airway is forced to elongate and relax. If the bronchospasm remains refractory, clinicians move to tertiary pharmacologic options for severe distress, including terbutaline and systemic epinephrine. For the most life-threatening exacerbations, recent critical care data supports the use of continuous intravenous ketamine infusions. Ketamine offers a highly specific dual clinical benefit. It promotes the release of catecholamines, which drives profound bronchodilation, while simultaneously preserving the patient's intrinsic respiratory drive. Escalating to these advanced systemic adjuncts disrupt refractory bronchospasm completely. At the cellular level, this buys the clinical team critical time and often prevents the immediate need for mechanical intubation. There is a defined threshold where pharmacologic adjuncts are no longer sufficient to maintain oxygenation, and mechanical ventilatory support must be initiated. This table outlines the indicators for acute respiratory failure. In older children and adults, the critical lab values are a PaO2 of less than 60 millimeters of mercury, or an arterial pH dropping below 7.35. These failing lab values are accompanied by physical symptoms of respiratory failure, extreme tachypnea, hemodynamic instability, altered mental status, and a silent chest, an indication of virtually zero air movement. Before resorting to endotracheal intubation, the optimal intervention to support the patient is non-invasive positive pressure ventilation, commonly delivered as BiPAP. This chart shows the results of a Cochrane review comparing standard medical care against NPPV in severe acute asthma. The data reveals a statistical shift favoring NPPV, demonstrating that it significantly reduces both overall hospitalizations and the necessity for endotracheal intubation. However, there are hard contraindications for non-invasive ventilation. If a patient becomes obtunded or serial blood gases reveal a rising PaCO2, NPPV has failed, and the patient must immediately progress to mechanical intubation. NPPV serves as a vital bridge, resting exhausted respiratory muscles to allow the pharmacologic treatments time to work. But clinicians must adhere strictly to these failure thresholds to prevent a sudden respiratory arrest. Once the acute crisis is managed, the patient is transitioned to the ward. Here, the clinical focus shifts to stabilization and the careful planning required to safely minimize the hospital length of stay. A subjective feeling of improvement is entirely insufficient for determining when a patient is ready to go home. Clinicians must rely on strict, objective physiological milestones. The specific discharge requirements demand a PAS score below 7, the ability to maintain an oxygen saturation above 92. Instead, the clinical requirement is to transition the patient directly onto a maintenance controller that includes an inhaled corticosteroid. The preferred option is Track 1 MART, utilizing ICS formoterol. Alongside the correct medication, the physician must provide a written, personalized asthma action plan to empower the patient in their own self-management. The critical care cycle is only truly successful when a patient leaves the hospital armed with the targeted anti-inflammatory regimen required to ensure they never return to the ICU.